I'm Fraser Stevenson. I am from New Rochelle, New York, which is just north of downtown Manhattan. I have been a nephrologist most of my life, starting with kind of a combined research academic career. All right, on to more and exciting endocrinology. We have a patient who feels tired all the time. Not very common patient complaint. She has a history of angina, and she feels tired for the last 6 months. She's gained weight, lethargic, feels cold, and has been using heavy blankets even in the summer. She's constipated with headaches and muscle cramps. All right. So very good. And note that her anginal chest pains are less frequent than they used to be, which is great. So she doesn't have as much angina, but she feels really tired and fatigued and out of it in the way we just described. Her past workup showed she had a 70% obstruction of her left main coronary artery at the time. They recommended CABG, but she didn't get it done at the time. And so she's been since then on beta blocker and isosorbide dinitrate at home for her problems. All right. So it's a little bit of ministry. What should probably, by the way, is reviewing yesterday. Well, let's assume this was fairly stable angina. It's getting a little better now, but if it's stable, what else should she have been on at home for better medical management for her angina? Yeah, almost. She has cardiovascular disease, so a statin and aspirin, absolutely. Clopidogrel is an option, but is not required. So definitely, I would say aspirin, yes, and statin, yes. In her, the beta blocker was fine. The nitrates are fine, and she should have probably been more. She should have really been more aggressively worked up. Risk assessment, treadmill, all that good stuff. But at minimum, she should have really been on an aspirins and a statin. Okay, in addition to what she was on. Now back to her. So the chest pain's better, but she feels worse, and she's feeling all this lethargy and fatigue. It's a pretty classic description where it is. Her skin is dry. Interestingly, she does not have thyromegaly, which is what you were expecting to see when you did the exam. She has a little bit of hypertension. Her DTRs are delayed, and the rest of her physical examination is unremarkable. So in a way, they presented a fairly routine case of symptomatic hypothyroidism by history, but interestingly, there isn't thyromegaly. All right, so I'm not sure what you guys thought about that when you went through the book's description, but it was an interesting concept. All right, and we'll talk a little bit more about the thyroid exam in just a second. Okay, so. Yes, we'll talk about the differential diagnosis of hypothyroidism in a moment, but in general, in this kind of woman coming in with these general symptoms of lassitude, fatigue, etc., what are the other kinds of things you think about in the outpatient world that would be common that you need to rule out in her? It may just be hypothyroidism, true, but what else could cause these similar symptoms? Depression, absolutely. Chronic infection, sure. A few other routine things. What other just makes people fatigued? Anemia, really good. So get a CBC, absolutely. Other things that make people fatigued, right? Chronic fatigue syndrome, yeah, we tend to forget that, but it's a real disease and it appears on board. So sure, it is a bit a step 3 studying makes you fatigued. Yeah, but not as bad as step 1, okay? So this is, I would call step 3 studying subacute fatigue rather than hyperacute changes seen with step 1. And sleep apnea, yeah, sleep disorders generally, by the way. So you need to do a good history to see how she's sleeping. Does she have depressive symptoms? Depression, of course, is a bit of a problem, and that depression could be instead of hypothyroidism, or depression could be the main symptom of her hypothyroidism, right? So there's a lot of other things that you want to consider in a diagnosis. But given the sort of things with the delayed reflexes and the other symptoms like the constipation and all, you're still probably most likely thinking there. And so these are at least some of the other things to consider. And in your initial workup, so make sure you do a CBC as well, and that you really do talk to her about her general depressive symptoms as well, okay? Notice she also was a little bit hypertensive. They make a point in the book about hypothyroidism causing hypertension. It does, but it's not an extraordinarily common cause. We already went over that yesterday. The main secondary causes we usually think about as the most common are Renal artery stenosis, yeah. Hyperaldosteronism, yeah. Pheo, much less likely, but also all causes of renal disease as well, all right? As well as more highly symptomatic things like coarctation or aortic dissection and such. So, hypothyroidism is on the list. It seems to cause some increasing fluid retention and such. It's not extraordinarily common. And diabetics, like I said, will tend to get it as well. That's reasonable. So I would say why hypothyroidism is a cause of secondary hypertension. It's not the most highly likely one, okay? So just a quick review, this should be familiar to you, I'm guessing, is the TSH is now our preferred test for all things thyroid. If you're going to do a second thing, always order a free T4 with or without a T3, but not a total. The T4 total is too unreliable because it has variable binding to thyroid binding globulin, and that can be affected by things like oral contraceptives and many others. So no real reason these days to order a total T3 or 4. So if you're ordering it on the simulation, make sure you're ordering free T4, but the first test really is TSH. The T4 is useful in following the patient and in the occasional case where you're trying to sort out secondary versus primary hypo or hyperthyroidism, but the best test is TSH. Now, and antibodies may come up, but not yet. Let's make a diagnosis first, and then we'll get a little more specific. I would start with just something simple. The other test that we use sometimes is the radioactive iodine uptake test. Notice that it tends to have increased activity in things like Graves'. We're talking about general thyroid testing now, not for specifically hypothyroid. I would not order this in this patient. But in general, this is a useful test for largely the hyperthyroid group. You'll have diffuse uptake in Graves' disease. In toxic nodule, you get uptake, but it'll be in a focused way, which you can sort of see on the scan. So it helps you anatomically to differentiate these two diseases a little bit. Now, it also may decrease in thyroiditis and sometimes patients who are taking thyroid hormone, but largely I would say its main indication in ordering it would be for distinction of Graves' disease from toxic nodule, all right? Primary hypothyroidism, which we're thinking this is, here's where we get to this issue of the goiter and not. The main causes we see really are the first three up here. Hashimoto's is the one that everyone's most familiar with. It's got positive thyroid antibodies. It's an autoimmune thyroiditis, a form of it. It is the most common, and it does give a goiter, all right? The only unusual thing about it is that it sometimes presents with a goiter, but with normal thyroid testing, with normal TSH, and then later evolves to hypothyroid. So you can have a euthyroid Hashimoto thyroiditis, especially early in the course of disease. Once it evolves, though, it really should give hypothyroidism, and then the TSH goes up in response. So that's the most common. We're increasingly becoming aware, and that's what this case is pointing out, of a related condition called atrophic thyroiditis. These are usually older patients, and they have positive antibodies, but they don't have a goiter. All right. Now, you're going to essentially treat them the same way. They have a high TSH, they have the high antibodies, but the difference is they may not have a goiter. So this is an increasing term that's in use now. It's called atrophic thyroiditis. All right. Atrophic. Then the other one to always remember is that anyone who has been hyperthyroid, who received a thyroidectomy, is going to be at risk for hypothyroidism afterwards. So this is also a fairly common thing you see out there, is people who received either radiation or surgery for Graves' disease, or even a toxic nodule, and then have been left with hypothyroidism afterwards. So a lot of people are on thyroid replacement after this. So really these top three are the best ones to think about. Iodine is really uncommon in the US, but you still could see it in some parts of the developing world. And some drugs, these are not likely to cause it on its own, but they'll likely contribute. Lithium, aspirin, and amiodarone will contribute and worsen hypothyroidism as well. Much less common, but we'll come back to during these talks, are secondary hypothyroidism. That's again a low TSH. Okay, so instead of high, these guys would be low, but you'd measure their T4 and it would also be low. And that would be due to low TSH due to somehow a tumor or trauma or some other pituitary lesion. And then very rare is tertiary, where there's a hypothalamic lesion. There's little TRH reduced, therefore low TSH. That's why it's called tertiary. This is very uncommon. All right. Secondary will come up periodically, and we'll talk about it again when we talk about pituitary failure. All right. Well, Hashimoto's is the one that's most common. It's an autoimmune inflammation. It is generally a non-tender goiter, all right? Not always, but in general, that's the key. If it's tender, think of other forms of thyroiditis. It should be a non-tender goiter. Initially euthyroid, then becomes hypothyroid, and you'll see this high TSH. The formal diagnosis comes with antithyroid antibodies. You can order any one of these. I checked it out on the simulations. If you just type antithyroid, it will pop up several of these. It doesn't really matter which ones you order. They're all confirmatory if you feel like you need to do it. They're not necessary to treat. That is, you're still going to manage the hypothyroidism clinically by giving thyroxine, yeah? But to make a diagnosis specifically of Hashimoto's, the antithyroids are helpful. And we'll come back to other forms of thyroiditis in just a minute. Okay? So general symptoms, we've already gone over most of these in this patient. Goiter in Hashimoto's, lethargy, constipation, cold intolerant, stiffness. These are sort of the biggies, but also carpal tunnel, menstrual abnormalities. With more chronic hypothyroidism is when we start getting into this depression. Comment on myxedema. Myxedema is that shiny, thickened skin, largely pretibial is what we're causing it. It's actually caused not by the thyroid, but by the autoantibodies. So interestingly, you see myxedema in Hashimoto's, but you also see it in Graves'. All right, so myxedema, pretibial myxedema, may be seen in either Graves' or Hashimoto's because it's due, just remember, it's due to the autoantibodies. Decreased appetite, hair loss, etc., and the DTR. So this patient is showing mixed symptoms of acute, early, and later hypothyroidism as well. What is our management? Pretty easy. We're going to restore the metabolic state by making the patient euthyroid with thyroxine. We're going to monitor the TSH every 6 weeks or so. It usually takes at least 6 weeks to stabilize these numbers after you start the thyroxine, so it's not an immediate process. So you're going to need to offer sort of monthly clinic follow-up and be checking the TSH and free T4. Remember, free T4. About every 4 to 6 weeks, and that's fine. One other little short comment on what's been termed myxedema coma, sometimes probably better called myxedema crisis. This is essentially just really severe hypothyroidism, and you get, along with all the other stuff, you may get acute hypotension and mental status changes. Right? This is unusual, but it's more of an emergency. They will also get very high doses of thyroxine, okay? But you're also going to need hemodynamic support. They may need to be even intubated and warmed because they get hypothermic. They may need pressors acutely in the ICU as well. All right, so just a sort of side point. This would be unusual to come up on the simulations. Occasionally pops up on multiple choice, just really severe hypothyroidism. In her, the seeming improving angina history is actually pretty common, meaning that, we're slowing down the body with the low thyroid, and therefore the myocardium is not in demand as much, and therefore the angina improves. So it sort of is a fake improvement in the clinical condition.